Welcome everyone to TALAHour. Thank you so much for joining us today. We're excited to have QIC Pharmacy with us. We have Christy Ulrich, there we go, and Leslie Morrow. Christy is the Director of Community Development for QIC, and Leslie is a pharmacist and consultant for QIC. And thank you so much for presenting today. Our topic today is from drug destruction to curtailing overflow, pharmacy and assisted living. I reached out because we frequently get questions around drug destruction, so I thought it was a great topic. Christy actually had a bunch of other topics she thought would fit very nicely into a TALAHour, and that's how this came about. We are recording this after we are finished today. When I get the recording back, I will send out the presentation and the recording to everyone. So if you can't catch all of it, or if you know someone who signed up and wasn't able to be on, they will get it. And then the other thing is, if you can use the chat function, and I will make sure that that is enabled for everyone to ask any questions. That will I'll try to monitor that and get the questions to them as we go along. If not, we'll wait until the very end for questions. And with that, turn it over to see Leslie. Please take it away.
Thank you so much. We do have a slideshow that we're prepared to present. First, wanted to introduce ourselves a little bit about our background. I have been working in pharmacy for 15 years, in long-term care for a little over 10. A majority of that has been here at QIC Pharmacy, and specifically a lot of adventures with Leslie here. We've spent countless hours in the communities, working, doing drug destruction, helping with cart audits when there have been issues in the building. I've spent many hours here in the pharmacy talking to families, working with nurses, doing training. And our goal as a pharmacy has always been solution driven, finding things that actually help our communities to be successful. So we have done a lot of research, and when new laws came out, Leslie will tell you a little bit about our experience there, but we were kind of hitting the ground running, like, how do we make this work, and what are going to be the best solutions for our partners. So that's a little bit about why we're so interested in this topic. It's because we've just spent years dealing with it. And it's become very important to both Leslie and myself to make sure partners and communities know what to do. So let me share my screen and then we can get going, and Leslie can introduce. Actually, yeah, you want to introduce yourself first?
Sure.
Sorry about that.
Okay. I'm Leslie Morrow, and I've been a pharmacist for 33 years. I've been with QIC for 15 years. I have experience in retail. I also have experience mail order, but the majority of my passion right now, especially over the last 15 years with QIC, has been with, I'm a consultant with QIC. I go to many facilities all over Texas doing overseeing their drug destruction, doing reviews, and doing audits. And so it's my passion for us to have excellence in customer and resident care, and to partner with communities.
And we have a lot of fun along the way.
Yes, we do.
Okay, now I'll start sharing my screen with you guys. All right. Okay, so the topic today, of course, like she said, is drug destruction and overflow. We picked overflow to talk about because it's something that we do see in the communities so much, and it can become such a burden on communities. So we do feel like it's an important thing to talk about because it does affect your drug destruction, but it also affects a lot of just your daily routines and activities. So without further ado, I will let Miss Leslie start to talk about how drug destruction became so complicated. Secure and Responsible Drug Disposal Act, the final rule.
Okay. On September 8th in 2014, the DEA made available for public view a final rule regarding the disposal of pharmaceutical controlled substances in accordance with the Controlled Substance Act. The final rule is available for public view, and you'll see the website. You can look at it. It wasn't necessarily put out like on email or anything to everyone.
Yeah.
It was just made available for public view. The Disposal Act gave the DEA authority to promulgate new regulations that allow ultimate users to deliver unused pharmaceutical controlled substances to appropriate entities for disposal in a safe and effective manner, consistent with effective control against diversion. While this opened up opportunities for the public, it also placed new limits on the options for the long-term care facilities. So let's just review some of the effects of the new rule on long-term care facilities. And yes, long-term care facilities does include assisted living and memory care communities. And we checked on this a lot.
Yeah.
A lot of research.
And arguing in emails with the DEA.
Yes, there was a lot of research involving DEA, the Texas State Board of Pharmacy, for several months.
Okay.
A pharmacist can no longer destroy controlled substances on site by any means other than placing the medication in an authorized collection receptacle managed by their pharmacy and located in the facility. That means a pharmacist also may not transport controlled substances for the purposes of disposal. A long-term care facility may dispose of current or former residents' pharmaceutical controlled substances by depositing them into the authorized collection receptacle located at the facility. Again, that's once it's reviewed by the pharmacist. We'll go over all that later.
Yeah.
If someone dies in the facility while in the possession of pharmaceutical controlled substances, any person lawfully entitled to dispose of the descendant's property may dispose of the descendant's pharmaceutical controlled substances, which means if you have a self-medicated resident who passes and their medications are in their room, you are not responsible for disposing their medications. Their POA or family member who removes their belongings should also handle their medications.
Yeah. And we see this a lot where families try to hand over medications that you've not managed for your residents and just hand them over for you to destroy and hand that responsibility to you. So the law clearly states from the DEA that this is not your responsibility. You don't need to take that liability on because you can't account for what happened to those medications and they were not in your possession. So it is the ultimate user who in this case would become the POA or the family member upon the resident's passing that would then accept that responsibility.
When disposing of pharmaceutical controlled substances by transferring those substances into a collection receptacle, such a disposal shall occur immediately, but no longer than 3 business days after the discontinuation of use by the long-term care resident. This is where the Texas Home Health Services regulations, the HH regulations, and the DEA Disposal Act first clash and make drug disposal very complicated for you and your communities. Unless you are a nursing home or hospital, you don't have a pharmacist on staff at your facility, so you can't meet that 3-day DEA rule. and the HHS rule of having a pharmacist review and sign your drug destruction laws. One, supervisor level of a long-term care facility designated by the authorized collector, which is the pharmacist, may assist in changing the collection receptacle inner liner under the supervision of the pharmacist. This means a medication aide cannot be delegated or asked to help the pharmacist or act as a witness in place of a supervisor.
Yeah, and we added this in because when we first started doing drug destruction, it was very common for a medication aide to be assigned to help the pharmacist in the room, taking care of popping out the pills, putting them in the kitty litter, you know, whatever the process was. But now that is not an option anymore. It must be a supervisor level employee that is there with the pharmacist witnessing the placement or disposal of any of the medications. So that is an important change to be aware of, to make sure that you schedule with the pharmacist to have that supervisor available for the entire time that the pharmacist is there on site.
Upon removal, the seal liners may be stored at the long-term care facility for up to 3 business days in a securely locked, substantially constructed cabinet or a securely locked room with controlled access, which means you need to create a place in your facility that only designated people have access to. According to the DEA, there are some long-term care facilities that will not have a collection receptacle, and there may be instances in where the long-term care residents are incapable of disposing of their own unused or unwanted medication. As ultimate users, the long-term care residents may use any of the disposal methods afforded other ultimate users that remain options even after the regulations took effect. Examples, the mail-back programs, flushing, over-the-counter medication disposal kits, etc. This is the second major problem once you figure in the Texas HHS regulations. If you're administering a resident's medications after they have been assessed, sorry, unable to safely manage it for themselves, you cannot be handing over medications that are expired or no longer on order for them. So now what?
So the current situation, what we're looking at right now, and this is why we've been hoping that some changes would come that would make it less frustrating for communities. But it does remain at this point a little complicated and confusing. So really all we can do is the best we can. The Health and Human Services state regulations at this point remove from cart immediately after discontinuation, expiration, or patient passing away. According to them, Texas pharmacists must destroy medications on site and sign medication destruction logs. You cannot flush medications or return discontinued expired medication to residents. However, according to the DEA, the federal regulations, medications must be disposed of within 72 hours from discontinuation, expiration, or patient moving or passing away. A pharmacist cannot physically destroy narcotics, and your options available according to them are DEA approved receptacle, mail-back program, return to patient, or patient flush. According to the Texas State Board of Pharmacy that the pharmacy has to abide by, we don't have a time limit on when your medications need to be destroyed. But again, a pharmacist cannot destroy narcotics anymore because we must follow the DEA protocols on that. No current facility scale mail-back program in Texas at this time allows narcotics to be included. We'll go over next, like what our actually options are. But the mail-back program is something like the Texas Takeaway, You see the packages available at the stores where you can get envelopes where you stick the medications down inside, seal it, and send it off. Those actually don't allow narcotics in Texas. So we get stuck again on what do you do with the narcotics? So the current DEA approved solutions for Texas assisted living, this is our reality check here. According to the DEA, return it to the resident, take away mail programs, take back events, flushing, or the MedSafe program, which was created in coordination with the DEA and Sharps came up with that program. Let's look at return to resident. It's only current orders and only if the resident is moving out. Y'all know you can sign one of those, I forgot what the form is called, but where you can sign out the medications with the count and have them sign that they're receiving it. But that is only for current and if they're moving out of the building. The takeaway mail program, one benefit, you can have it on site. We have seen this in some communities. They have this box. Some other pharmacies are supplying this. The pharmacists can sign and they can seal the box, but it's non-narcotics only. So then you still have to deal with your narcotics on that one. Take back events. We see the police, we see the signs. They do this a couple times every year, and it's a great program, especially for people living in their homes that, don't have much access to anything else. But it's off-site, which means your staff would have to transport the medications, which is not a great idea. And there's no pharmacist, so there would be nobody there to sign your required documentation. And again, the infrequency of it, you'd be stashing that stuff for 6 months or more until the next take back event. And then flushing, it's never an option for assisted living. The MedSafe program, it is on site. The pharmacist can sign and seal the liner. The narcotics are included. You have frequency options, which means you can do it quarterly, you can do it every 2 months, you can do it every 6 months, depending on the size of your community and the size of the MedSafe that you get in the building. So return to resident, not a great idea. Take away mail program, not a great idea. Take back, no. Flushing, definitely not. But the MedSafe program is great. This is actually what we use with all of our, 70 plus communities now.
Yes.
And it has made drug destruction so much quicker and easier for us, but it's also made it a lot safer for the communities. So this is what we'll be focusing on is the DEA approved receptacle method for the rest of the presentation. A lot of the basic, logging your medications and things like that will be across the board, whether you have the MedSafe or not. But because this is the best option right now that exists out there, this is what we'll be focusing on. So what is a MedSafe? We call it the big blue mailbox. Yes.
Before you get some clarification.
Yeah.
If you'll go back one slide.
Okay.
On the return of resident, if a resident passes away, you can, and if they kept the medications within their own room, you can allow the family to take those.
Yes, because according to the DEA, you were never the ultimate user if they are self-medicating. So it would be like in their own apartment or their own home that they had possession of those. So you would not be considered the ultimate user. When you're administering the medications, you have them in your possession, they're in your med cart, in your med room, then you are considered at that point the ultimate user. And the responsibility is for you to dispose of them. But they also said, if they haven't passed, then according to the DEA, you can hand those right back to the patient after they get discontinued and let them flush them. Well, we know that's not a good idea in Texas assisted living, regardless, if you're flushing or not, but that's kind of where where that difference is. If it's in their room and they're self-med, then it's not your responsibility.
But if you,
How, we have another question. How expensive is a med safe?
It varies, and it can, I'm like, what we ran into, it's kind of buying power also. Like Walmart can get something much cheaper than a QIC pharmacy. So the contract that we have with them, I think, what does it run a month for the communities? Do you remember? I think it's like less than 200, I think, a month that we charge. For us right now, I think it's a little less than $200 a month that we charge the communities. And that just covers that liner and the service.
The collection?
Yeah, because they get billed directly to the pharmacy. So we just split that up into a monthly. I think we have like a quarterly charge that we break down into a monthly and pass that on to the communities. But we also get the biggest med safe there is. So there are smaller ones available where the cost would be lower. And I think they're working on some other options as well, like cabinets and stuff. But we get the big dog 32 gallon safe. And for the larger assisted livings, quarterly is, just barely cutting it as far as stuff fitting in it. But we do that every 3 months.
I have another question. Can we use a med destroyer?
You mean like where you place the medications into a container that contains liquid or something else to destroy it?
Yes.
Yeah, no.
no,
Possibly with OTCs, not narcotics. They cannot be destroyed on site. They have to be transported to, like Sharps has a site they transfer them to where they're incinerated, where the box is just incinerated. They're trying to prevent any of that getting into the groundwater or being transportable easily by any non-authorized person. Yeah, it like I said, it's gotten very complicated, and that's why I was really excited when you invited us to do this to kind of help. So you guys know the pharmacies are really trying to make this work, but with them clashing in two major places right now, it puts everybody in an awkward spot. And you just really have to do the best that you can. And we'll kind of go over more of that, but this is the best we've found so far that makes it as easy as it can be.
Thank you.
Yeah. Okay, so the Big Blue Mailbox. This was created by Sharps Incorporated in coordination with the DEA. It's they call an unused ultimate user medication disposal system. It's very easy to operate. You can have narcotics and non-controlled over-the-counter medicines, everything commingled. The MedSafe meets the requirements of the DEA Controlled Substances Act. The MedSafe combines a stainless steel collection receptacle with a removable prepaid ship-back inner liner. When the inner liner fills, authorized persons can safely remove the liner from the collection receptacle, seal it, and return it via common carrier. Inner liners are treated using the DEA preferred method of disposal, incineration, rendering the pharmaceuticals non-retrievable. It's 14 gauge powder coated steel, so it's not easily, you're not going to have somebody able to easily get into it to remove anything. It has a one-way medicine drop with locking door. That's why we call it the mailbox. You can put stuff in, but your arm's not going to get in there to get anything out. Double lock front door access. So you're going to have a key and the pharmacy is going to have a key. So nobody's going to be able to get in there unless both parties are present. It secures to a permanent structure. So this is not just going to be sitting there. It's going to be bolted into the floor or into the wall. The serialized inner liners, again, with prepaid return. Unique identification number on inner liner that enables tracking. So you're able to track and get proof of destruction once that it gets to Sharps and gets incinerated. So you can have that for your records. I will pass it on to Leslie to talk about basic drug destruction procedures and documentation.
So, logging medications for disposal, when medications have been discontinued by the doctor, have expired, or the resident has passed away and their medication still on hand, they must be removed from the medication cart immediately and logged for destruction correctly. Your company or pharmacy will provide you with a prescription drug inventory form for this purpose. Every pill, capsule, cream, eye drop, suppository, liquid should be accounted for. The key to simplifying the destruction process is logging the medications as you put them from the med cart. We suggest you do not wait until the last minute when you have boxes of medications to sort through. Controlled substances should be logged immediately to prevent diversion. You want to see that the amount pulled from the cart is the amount being destroyed. I will also add on this that if it is a controlled substance and it is refused by the resident, it needs to be put in a little envelope that is usually supplied by the communities that they have. They write the prescription number, the patient's name. All those little envelopes are put together and given to the nurse for her to lock up until the pharmacist comes to check off on that.
Yeah, those do not go in the sharps box on the side of your med cart. We see that too often where somebody refuses medications and the med aides are pouring those pills inside with the needles. That's not where they go. So definitely want to encourage every community to make sure they have those envelopes that can seal once they've placed them in there, and make that mandatory, because those pills do not need to go into those sharps containers.
Right.
Or get flushed or thrown out. That's a no-no.
So all non-controlled medications and over-the-counter items may be logged together on the same form. All controlled substances, controls schedules 3 through 5, must be separated and logged together on their own form or forms. And then all controlled substances that are schedule 2 must be separated and logged on their own forms. Required information for destruction inventory, and that is our form that we use for our facilities.
Yeah, yours might look different, but
First is required the facility name and address. When starting a new form, indicate if the items are non-controlled or controlled substances by placing a check mark next to either dangerous drugs, which would be non-controlled.
oops, sorry.
It's okay. Or controlled substances. The facility supervisor name and signature must be there. The pharmacist's name and signature, and then also the witness name and signature for controls. They must sign in person. They cannot sign in advance. The date of destruction is the day the items are placed inside the med safe. For controls, this will be filled out for the date on there when the pharmacist is present. For each medication or supplement logged, you need to have the date it was dispensed by the pharmacy, the prescription number, if it's applicable. If it's over the counter, it's not going to have a prescription number necessarily. The name of the dispensing pharmacy, the name and strength of the drug, the quantity to be destroyed, and the initial of the employee who logs the medication. So you're going to always log control 2 prescriptions together on a separate drug inventory sheet for the pharmacist. So schedule 2 is the highest level of controls. That includes narcotic drugs with the highest potential for abuse, but with current accepted medical use for treatment. Schedule 2 narcotics includes, let's see, non-narcotic drugs with high potential for abuse. So the main Schedule 2s that we thought of examples of are like amphetamines, codeine, fentanyl, hydrocodone, hydromorphone, meperidine, methadone, methylphenidate or Ritalin, morphine, Nucynta, and oxycodone. Schedule 3, 3 through 5 is going to be on another sheet. So Schedule 3 is going to be like your Tylenol with codeine or acetaminophen with codeine, your aspirin with codeine. Schedule 4 is going to be, has a combination of all other control medications. It has, I call them all your PAMs: alprazolam, clonazepam, diazepam, lorazepam, midazolam, temazepam. All those are on there. Your generic Soma is on there. Modafinil is on there. Venteramine's on there. Zolpidem or Ambien's on there. There's other examples there. Schedule 5s are going to be your least abusive things. Those are usually include your narcotic cough syrups, and also things with ephedrine and pseudoephedrine and phenylpropanolamine products. So you basically have your diphenoxylate with atropine, which is going to be your generic Lamodal, your guaifenesin with codeine, your Lyrica, your promethazine with codeine, cough syrup again, and your Vimpat. Once logged, all of the non-controlled items can be placed in the MedSafe right away or held for the administrator to review per your company policy. All the controlled substances, on the other hand, the 2 through 5, must be given to a designated responsible supervisor level employee to be securely stored under double lock in a container that cannot be transported, such as a built-in safe or a cabinet that is secured to the floor or wall in a controlled access room until the pharmacist comes and is present to review them. To limit issues with complying with the DEA 3-day rule, get as close as you can to the secure and non-retrievable. If you do not have something like this available, we suggest contacting your partner pharmacy to request an additional narcotic box used in their med carts that can be bolted down in a cabinet or a shelf in a locking closet or on top of your med safe.
Yeah, we do this for a lot of our communities, so we highly suggest that it's really, really helpful. There's a lot of those cabinets built into the walls, and you add manually a lock. We've seen that they're very easily pickable, and they're very easy to open. And we've seen maintenance men that were able to get in with scissors. So if you can get one of those narcotic lock boxes, they're much more secure, and they're easy to bolt in to a cabinet. Sorry.
Perpetual count sheet should be kept stored with each controlled substance to allow the pharmacist to verify the final count before signing the prescription inventory form. That is to protect the nurse's license as well, to make sure that what's being destroyed is what's actually what you have. It also helps prevent diversion. Once verified, the controlled substance may be placed in a med safe, and then the perpetual count sheet can be updated with the date and time the medication was placed in the med safe, and then filed according to your company policy. Some facilities will put all those perpetual sheets in one binder. Some of them will put them in the patient's chart. If there is a count discrepancy, the pharmacist should set the medication aside for the administrator to investigate. Once medications are placed inside the med safe, they are by DEA standards and rules destroyed or rendered non-retrievable. This means that once they go into the med safe, they cannot come back out. Not even the pharmacist is allowed to remove anything, even when changing out and sealing the liner for shipment. If you cannot contract with a pharmacy that provides the MedSafe system, your company may be able to contract with Sharps directly if your pharmacy will agree to manage the process and provide their DEA number for reporting.
Got a couple of questions.
Uh-huh.
For a
Okay.
small community that does not have an on-site pharmacy, what pharmacy would come out to the facility to do the sign-off?
Well, that's a good question. That's one of those situations that does make it difficult. If you don't have a partner pharmacy. I know, we partner with a lot of small group homes, and small communities. And they will often make it to where, if you have multiple locations, they will house the MedSafe in one of like their 4 or 5 homes. And then when the pharmacist comes out for logging and destruction, they will have to transport all of that, which is not the best. You don't, if you have 2 supervisor level employees transporting that, it's better than not having it destroyed at all. The other, that's really the best option, is to find some way to have.
They do have smaller med safes as
Yeah.
well. So if they could purchase a smaller med safe as well, it's really the best way to make sure that you meet all the proper requirements.
Yeah, and I'm gonna put in a plug for QIC Pharmacy.
Thank you.
Thank you.
It's one of those companies that provide service. If you look at, and they're one of our talent industry partners. So I'm being a little self-serving there. If you look at our industry partner list, we actually have some other pharmacy companies that provide services depending on where you're at in the state. So please look at our TALAHour industry partner list, and you'll see some names of other companies that may be able to provide and assist in this area.
And we even have a community in another state that we couldn't provide services for, but because their company is a good partner of ours, we do manage that, like we provide that MedSafe for them. So there may be more options out there if you have a statewide pharmacy that may be partnered with your company in other areas, where they might be able to assist you with that. So I'm sure Diana can give you my email also if you want that after, or I can give it to you after. And we can kind of talk more about your specific situation, and maybe I can help, research and find, what might be some good options for you. All right. Do we have any other questions? Or do you want me?
Let's see, make sure. There was a question about, is that only narcotics, but I don't know the content of the question. Sorry about that. If you want to.
Well, I can kind of,
Okay.
yeah, because that's what throws it all off, is it's the rules regarding the narcotics that threw off all drug distractions. It made it all complicated. So the reason why, we like the MedSafe is because you can do all of it. So there's no regulation saying that you have to use a MedSafe for over the counters, or you have to use it for like non-narcotic medications. It just makes it easier if you're going to have it anyways, because you have to do something with the narcotics to put them all together. So you've got one system in place. But you can continue to use the takeaway and other options that are available for your non-narcotics and your over-the-counters. But because most communities do handle narcotics, you have to have some kind of system in place to deal with those. So it just makes sense to do it all together. So I kind of know what he was talking about, because it's, yeah, do we have to do this for everything? You don't have to, but it makes sense to do it all with one system. If it means you can get away with a smaller med safe, only putting the narcotics in it, that might be a budget option. And use a takeaway box or mail back, you know, for the non-narcotic stuff or other method. But yeah, as long as you have the controls in the building, you're going to have some DEA compliant or as close as possible system. No, we're just starting this one.
We're starting this one.
Yeah, we got a lot.
Sorry,
Zone
got
out.
off track. The facility will ensure that only non-hazardous drugs prescribed to residents only are placed into the MedSafe receptacle. In other words, not anybody can bring their medicines in. It has to be only for the residents. You're not to place any aerosol containers such as inhalers into the MedSafe. Hold these in another location until the pharmacy staff is present. I take these back. There's a separate biohazard for those and destroy them separately, along with any other full sharps containers. And the reason why you can't put any aerosol containers in there is with the propellant is because it is incinerated. If you do put those in there, it's incinerated, it would explode.
Yeah,
So we
that's
don't
for the
want that.
safety of the Sharps facility. They
Yes.
don't want explosions.
So any authorized supervisor level employee of the long-term care facility, like the charge nurse, the RSD, or the executive director, will be responsible for maintaining one key designated for lock A of the MedSafe. The pharmacy will maintain the log B for the MedSafe. This prevents the receptacle from being opened without both sides being present. Again, it prevents diversion. The pharmacy shall send a licensed pharmacist quarterly or determined by the contract to the facility on a predetermined schedule to verify and sign the documents for all controlled substances being held for destruction, along with the authorized employee of the facility. The pharmacist will witness to the controlled substances being placed into the MedSafe at that time. The pharmacist will then assist with changing out the liner. We also will sign the documents for the non-controlled medications as well at that time. The pharmacist, as well as the long-term care authorized employee, shall document that the liner was removed, sealed, and packaged and stored at the facility in a securely locked room with controlled access for no longer than 3 business days. So what I do when I do this is it is secured and sealed. It has tape on it. And I put my initials on it and it is locked up. I do schedule with the people who pick it up. I put in the liner number, the tracking number, and I schedule it for usually to be picked up the next business day. The facility will coordinate the pickup of the sealed package MedSafe liner by UPS, which is the common carrier, for transfer to the Sharps destruction facility, and the document such transfer. The phone number for Sharps can be found on the instruction sheet in the plastic pocket on the side of each liner.
Yeah, so this paperwork is all supplied with the liner itself. It's on the side, so there's nothing you have to find. Usually the facility is responsible, but we have awesome Miss Leslie who is over over and above, that does schedule that for our partners. But they do need to make sure on that document that you will keep with your perpetuals, or not with your destruction log, that you do sign and witness when the box is picked up by the common carrier. So you need to make sure that you have that documentation complete, and that can be filed along with the narcotic count sheets from that destruction, so you can keep it all together. All right, so that was the basics on drug destruction. Before I move on to talking about overflow, does anybody have any questions regarding drug destruction?
We did have a question of, do you have to have a safe secured to the wall or the floor if the narcotics are behind 2 locked doors?
Yes. Yeah, that is part of the new DEA rule that does affect the communities. It does have to be something that is secured physically, so that can't be moved. So I've seen communities where they have their narcotics in like a big tackle box, and that's a no-no. Even though it may have a lock on it and it's in a med room that's locked, that's no longer enough for the DEA. It needs to be something non-movable.
Okay, last one on this topic, so we can get to, can the narcotics be placed in a safe with a combination and a key in a locked room?
As long as that safe is not movable, yes. So if you can bolt that safe into the wall or the cabinet or the floor or something where it can't be picked up and moved. Now, if you have a giant gun safe that like is 1,000 pounds, then I'm sure they'll let you buy on that one. But if it is a smaller safe, it may still need to be somehow secured.
You would probably want that in the nurse's office. If you did have that option, you wouldn't want everyone with access to that, watching the person put the code in or whatever. You would want that only in the nurse's office, so that the one person professional can do that.
Yeah.
Okay, this is the last one on this topic. When did these new laws go into effect?
That was 2014. So the problem was they put this rule out there, but they didn't notify. Like, I mean, there wasn't a way for them to just send out flyers or emails and mass information. We wish they had. It kind of came out around the same time that hydrocodone became a C2, and I think everybody was so focused on that because it affected everything. I mean, everybody having taken that so much and having to get now triplicates for that, and the doctors, and that became such a focus that this was kind of in the background, and we actually found out by accident ourselves. Leslie wants to tell that story, but it was for us a big shock also, and we had to scramble to figure out what we were going to do, because we were still destroying on site a couple of years after it had supposedly changed.
Yeah, it was not highly publicized at all. I actually accidentally came across this when I had to call the Texas State Board of Pharmacy regarding another question. And it was when hydrocodone and tramadol, it was when hydrocodone went C2, it was when tramadol became a controlled substance. It was that year. And they started asking me questions about drug destruction, and the person I was talking to at the state board was saying, well, you do know that now narcotics are not able to be destroyed by the pharmacist on site. And I said, I did not know about that. And so she went over all the new recommendations, or not recommendations, new laws that were not publicized. And so then I asked, how are they supposed to lawfully destroy then? They did not have the answers to that at that time. So at that point, I myself, our owner, Jeff Olsabrook, went to great lengths to talk with the Texas State Board of Pharmacy, the DEA, exactly how lawfully are we supposed to destroy narcotics and do what they're asking, and make sure everything is how it's supposed to be. So not everyone is aware, not all pharmacies or consultants are aware of this. So again, we happened to come upon it by surprise, honestly, but this is the most current, up to date.
Yeah, I think you almost had a panic attack.
Yes,
You
I
pulled
did.
over.
I had to pull over when she was talking to me because I didn't know about any of this. And so, like I said, we went to great lengths to find out what is compliant with the DEA, the Texas State Board, everything with drug destruction. And the MedSafe is the most compliant.
Yeah, it's one thing to have pharmacies, not know about it, but once you do know about it, there are still some pharmacies that are still not doing it the right way. And we're not that kind of pharmacy. We're going to make sure we're doing everything as above board and legal as possible, because we don't want our partners getting in trouble. If you do have diversion and the DEA comes in and they're, well, what are you doing? Destroying medications. You can't do that. We just don't ever want our partners to be in a position like that, nor ourselves. So it's just not a risk that we're willing to take.
We had a question, has anyone ever been cited on this? I don't know about citations. I do know that there have been some high profile diversions that have happened in the state of Texas. That has called in a lot of scrutiny, so I would assume that resulted in some pretty hefty citations and fines.
Yeah.
Yes.
I don't know any specifics on that, but it's something, I'm sure if they took the time and effort. And
Christy, do you know, is there another company out there like MedSafe that is providing the receptacles and the liners and everything?
There may be at this point, because we haven't had any reason to look elsewhere. We've been very, very satisfied with the MedSafe. I should have looked into that probably before I came on here. But I just, the stuff I see most often in communities when we first partner and come on with a new community is stuff like those takeaway boxes. And that seems to be what a lot of pharmacies are trying to get away with, but they do clearly state on the top that narcotics cannot be included in that box. I hope they come out with more options, and I can do some research and find out if they have and follow up with you, and let you know if there is something. But at this time, I don't know of any. It would be a very expensive venture, but they were backed by the DEA sharps, so I'm sure they had the funding to do it.
Thank you. Let's talk about overflow.
Okay, so this is something we see a lot of, Leslie and I, when we're out at the communities, and it drives us crazy for you guys, as well as for us. We're trying to help sort through and make sense of residents' medications. So it's definitely something I felt was really important to talk about today. So with that being said, let's discuss reducing overflow. This is the biggest thing. It is okay to be honest. I see too much communities that are really wanting to get people in the building. And it may be your person who does the marketing or who does intake may not be as familiar. It may take some training and talking to the front offices, getting them on the same page with the care side to understand the importance would be really, really helpful. And we encourage those kinds of meetings to discuss. But yeah, so overflow, we'll go on now. Overflow is usually a multi-source problem, but it's mostly preventable with communication. We hear a lot of communities that worry if they, like I said, discuss the pharmacy needs and preferences too much before a resident moves in. They might make families overly concerned about cost. But not discussing some basic needs and expectations for the community best practices leads to a lot of later frustration on all sides. At the pharmacy, we get to hear all about it from both sides. If it will improve your patient care and reduce the level of stress your employees carry, it needs to be said. And it needs to be said sooner than later. So what we're going to discuss is well-meaning family suppliers, bulk size over-the-counter items, the importance of using one pharmacy, communicating a change of pharmacy to all physicians and involved care providers, and when hospice comes into the picture, what best to do there. So well-meaning family suppliers, we all know these families. They're trying to stretch every dollar, look for every deal, or they want to be fully in charge, not quite ready to give up control to the community. Some examples, they thought of mom and dad while they were out and they picked up whatever refills the pharmacy had available. Didn't call and ask you guys to find out that, she'd been refusing or other things had come up, and you still have, 30 days on hand, and now you've got a whole new bottle in your cart. They have autofill set up for 90-day supplies with Mrs. Smith's mail order pharmacy, but they set it up for every 75 days. Like as soon as the insurance would go through, they're filling it and sending you a new 90-day supply. And over time, that's going to stack up. They went to Kroger and they had a buy one, get one free sale on supplements. And we see that a lot at Kroger and Walgreens. So they brought you 2 300 count bottles of everything. Mom needs vitamin B12, 2,500 micrograms, but the 3,000 microgram was on sale. So now you've got a bottle you can't even use because it doesn't match the order on your cart. And hopefully your med aid that receives it will notice the strength is not correct and won't put it in the cart. But we see that unfortunately too often where it does make it in the cart, even though it does not match the order. A trip to the doctor leads to order changes that the family helpfully fills locally, but they forgot to keep a copy of the order to give to you, or they give it to your med aid completely forgetting to mention the order has changed. So now you've got meds in the cart that you're not aware of or that don't match your MAR. This doesn't cause overflow, but annoys me for you. That would be super frustrating. So it's just something that we've noticed happens a lot. So that's part of the conversation with family members, is making sure that they know how essential and important it is to communicate with you guys and get you those orders, or to let you handle it instead of going and filling it themselves. Mail order, I threw this in there. Mail order is not cheaper if a medication error causes adverse effects. There can be high costs not measured by dollars. We hear that so much, families wanting to save money by getting those 90-day supplies, but is that really going to make things better for the patient in the long run? It's better to have the awkward conversation as soon as possible, be truthful and direct, and make sure you tell them that your community policies are in place to ensure the best possible outcomes for every resident. While you can sympathize with cost concerns, every family and resident is entrusting you and your staff to know and guard against non-monetary costs. So those medication errors, it just happens too often when we're just stacking bottles and boxes inside those med carts. One 300-day supply of a multivitamin may save them money, but it will take up very valuable space in your medication cart. One bulk bottle will typically take up the space of 4 or more blister cards. If they also bring you the bulk size fiber and the 400 count generic Tylenol, they will probably have to get stored in one of the bottom drawers where meds go to be forgotten. Maybe not in your community, but a lot of the communities where we've done audits, once those giant bottles get stuck down in the bottom drawer or on the side, we see a lot of did not administer because the medication's not available because they forgot that it's down there at the bottom. While you probably don't want to mention that last part, you can say that you have to ensure there is room for everyone's medications to fit inside of your med cart. The community has to manage the destruction of medications that get discontinued, and they all have to fit inside the MedSafe liner. Assisted living residents have more medication changes than patients living at home. So 90+ day supplies are often wasted and put the resident at higher risk of medication errors. Bulk is not better. Bulk has non-monetary costs and unwanted risk. So the expectation of OTC, I'm going too fast, set the expectation of OTC bottles with 100 count or less for pills and capsules, 30-day supplies for powders, creams, etc. If they have to use mail order for high dollar medications, have them bring you 1 bottle a month. While you are taking care of the residents, you are also the best advocate for you and your staff. And that's what I really want to encourage and push, is that there is nothing wrong with having that conversation with families and saying, you know, you're trusting us to take care of mom or dad. This is the best way that we can do it. You can even create a guideline of, you know, expectations or requests for new move-ins, saying no OTC bottles greater than 100 count, you know, that this is going to enable you to provide the best level of care. And it's important, reducing the stress level on your employees and yourself is a big part of that, because of caregiver fatigue is a real thing that you guys have to battle with, and having to deal with all this bulk stuff and mess adds to that. So setting those clear expectations, you know, you'll have some that will balk against it, but being open and honest and directing it towards best patient care is the best way to have that conversation with families. I've had that conversation many times, and very few don't understand. The importance of using one pharmacy for safety and budget. This could be a whole talk of its own, especially if you want to use QIC pharmacy, because there's so many great benefits. But it's an important part of the conversation with residents and their families. It is okay to ask them to pick one pharmacy, especially your community partner. Encourage them to introduce themselves to the pharmacy staff. Ask them to tell the pharmacy to make note of any budget concerns. If there's a dollar amount they don't want a prescription exceeding without a phone call for permission, etc. Pharmacies welcome that information, and a lot of people don't realize that. You're not bothering us, they're not upsetting us. It helps us tremendously to know if there are budget concerns. If there's a patient who has a limited income, getting that information to the pharmacy is going to reduce a lot of frustration and stress. You're not going to get big bills because we can watch out for that, discuss it with family, discuss it with doctors, make changes if necessary. But it's really, really helpful and builds that relationship. Using one pharmacy for partnership and allows for partnership and trust building, as I was saying. When a pharmacist is filling for a patient who has everything on file with them, they can monitor for potential dangers and better counsel patients and families, especially a long-term care pharmacy specialized in senior care. They can keep the PCP, the heart doctor, or the GI doctor from interfering with each other's orders or prescribing similar drugs for the same diagnosis. And our pharmacists spend a lot of time doing this. where we get multiple doctors prescribing, a hospitalist, a hospice doctor, PCP, all these different doctors who are trying to take care of the resident and great intentions, but they don't have the full information, knowing what's already been prescribed for the patient. Then we can step in and make those phone calls and have those discussions. But we wouldn't be able to do that if we didn't have the entire patient's medication file with us. And that can get scary pretty fast. Because of their elevated needs and their elevated risk, once the patient enters assisted living, their pharmacy should become a trusted member of their care team, as important as their PCP. They may not always get the best deals on OTCs, but the outcomes will be better and the long-term cost of care can be much lower. The next topic, this is something that affects us at the pharmacy quite a bit, and it greatly affects the patients and the families also. Always communicate a change of pharmacy to all physicians and care providers. This may be something the family has decided to change, or if you're switching from one partner pharmacy to another. But this is an issue for everybody. When the previous pharmacy is not informed that they are no longer the patient's filling pharmacy, multiple problems usually arise. We see these things come up daily. The new pharmacy tries to fill a medication, but the old one had it on autofill and it gets delivered or is waiting to be picked up. The new pharmacy will either fill it as cash to make sure the medication gets to the patient, or they might hold the fill until you or the family can get the other pharmacy to reverse the billing. Now you have overflow or possible missed doses. If they pick it up from the old pharmacy, the new one can't fill it until it runs out. If you're using a compliance system like our calendar day cycle, this creates a big headache. The doctor sends all of the patient's new medications and refills to the old pharmacy. You keep asking the new pharmacy when they will be delivered, and they keep telling you they don't have the orders. Delays and frustration. Again, not what you want for your staff. The patient is on cycle, but the family decides to set them up on mail order for the brand name drugs. So the cycle pharmacy sends out a month's supply, and the mail order uses an override to bill and send a 90-day supply. Now you have overflow and frustration. The patient is on cycle and the family decides to set them up on mail order days before their cycle is set to be filled, but the delivery takes 14 days to arrive. Now you don't have meds, and now you have health risk and frustration. So it is just essential that that information gets communicated to everyone involved. The common theme here is frustration. Frustration does not help your community provide good care. Now, hospice. We love hospice. I mean, they're essential as we are. But communicating when somebody goes on hospice is often one of the biggest things that falls through the cracks with long-term care pharmacy. We often find out much later that they've gone on hospice. We get phone calls from families that they're receiving bills for stuff that hospice should be covering. It's such a big deal for us because we can't be billing for hospice medicine on Part D. And so we could be audited and fined even if we didn't know about it. So this is a big thing, but one of the main reasons I'm including it is the overflow issue, because if you're getting prescriptions filled from the hospice and then also from your partner pharmacy or the other pharmacy and nobody stops it, we've seen 6 months worth of meds stack up in some communities where they just put it, in overflow just in case, or we don't know why, but it will stack up. And that's a huge waste, and not fair for the resident or for you. So when hospice comes into the picture, again, one of the big causes of overflow in communities is lack of communication when a resident goes on hospice. Because hospice companies bill a different part of the patient's Medicare, they could bill and send the same medications as the retail long-term care pharmacy for months if it's not caught and stopped. A retail long-term care pharmacy that bills Part D could be audited and fined for billing for a medication covered by hospice. So communication is extremely important for everyone involved. As soon as a patient is admitted to hospice, make sure you get a detailed list of the medications they will cover or provide. They are required to provide this to the nurse at the community. That's a big thing we see also is hospices forgetting or waiting to get approvals and not getting you that information. And that causes a huge delay in getting those medications straightened out. Send this to the patient's pharmacy immediately and call to let them know it's coming so we can immediately stop filling any medicines we should not be filling. If your community has a partner pharmacy like QIC, the hospice can often provide the pharmacy with billing information to allow continued service and more consistency for your staff. And we do this for a lot of our partners for their routine medications, keeping them in the same packaging, keeping them being delivered from the same pharmacy, ordering from the same pharmacy, reduces a lot of headaches for you guys. So there are many hospices out there like Encompass, and there's a couple other big ones that we work with that can provide us with billing information and that covered medicine list. And then we just start filling them every 14 or 15 days, whatever they're approved for. But it doesn't stop coming from us. They just cover the comfort kits and things that are needed stat because they have a pharmacy partner, maybe that's 24 hours. But whenever you have a partner pharmacy, especially with a compliance packaging or a system in place, it is definitely better if you can have that pharmacy continue to fill. If they can't provide this, notify the pharmacy to hold filling any medications covered by hospice.
And Christy, we are over time.
Oh, we are? Okay.
Oh, yeah. I want you to hit your last
Okay.
points there, though. If you have someone that moves out or passes away, if you can touch upon that really quickly.
Okay. So yeah, keep pharmacy in loop. Finally, when a resident moves out or passes away, notify the pharmacy the same day. That is so huge. Billing Medicare for a deceased person is a huge no-no and upsets family members when they're already mourning. Since their insurance may not cancel for a few months, the overflow can stack up. If they've moved, they may not be able to fill their prescriptions at the new pharmacy or the new community if the pharmacy has sent their medications to you. And we get this so often where we get a call from the family that a patient died 4 months ago and we've been billing and sending their cycle and we were never notified that they died. So now you've got those somewhere in the building and could get in trouble for billing for a deceased person. So that is huge, and we need y'all's help. The pharmacies need y'all's help to make sure that's not happening. But that's all that I have. The floor is now yours. We appreciate you guys. Yeah, I'll hand it over to you, Diana.
Okay. All right, everyone. Thank you for the discussion. Christy, Leslie, that was really fascinating. Lots of great information there. We will be sending out the slides and the recording later on this afternoon, so look for that. Everyone that registered will get it. So if you have team members that weren't able to attend, they will get it as long as they register. Thank you as always, everyone, for attending. Please look for our next things that we've got coming out on November 9th, our next TALAHour. We have integration of independent living into assisted living. We're going to have Pi Architect and Civitas Senior Living talking about different concerns with different models and operational concerns, development concerns. So that'll be very interesting. We have a Lynn's article that's out dealing with our conference. Christy is how I originally met her. They are huge fans of our conference and they always get real excited about our theme. That article just came out talking about some of the news things that are on the horizon with our conference next year. We have a new leadership development series that is out. If you want to check that out, please visit the website. And if you do not get our monthly newsletter, please sign up at TALAHour. The View comes out every month. It's got some great information in it. Carmen was texting me while we were doing this TALAHour today to talk about maybe incorporating some of the stuff that was discussed today into an Under the Dome. And that's the part of the newsletter where our VP of Public Policy, Carmen Tilton, takes new regulations or clarifications that we're getting for the Human Service Commission, Health and Human Service Commission, and gives you that information so that y'all can do your jobs easier and so that you can follow regulations that are required. So those are some things to be on the lookout for. And with that, ladies, once again, thank you. Great content. I learned so much.
Well, we appreciate you asking. I mean, I love this. So thank you so much.
Thank you.
Good. And everyone have a great day, and we hope to see you next month. Take care.
Bye, guys.
Bye.